previous note why they're coming. But there's also acute visits. And at that time, I will ask them, so what are you here for today? And they'll generally tell me what it is. But I want to make sure that it's concise and that I clarify that. So they might say, well, I'm here to talk about my blood pressure or my diabetes. But then what I do is I go into that history of the present illness and get a little more information about that primary concern. So, for example, if they come in and they're feeling like they have muscle aches and pains, then I'm going to go through all my muscle aches and pains patterns. So I'm going to say, well, okay, do you have a fever? Do you have a sore throat? Did you take anything for it? Are you feeling better? When did it start? So that I have a little bit of a picture or a story that goes with their chief complaint. And I'm sure that you do that also when you're looking at patient problems. In your professional judgment, you've kind of got to clarify it and put some associated findings and associated characteristics along with that chief complaint. So when I say history of present illness, that's what I'm talking about. I'm talking about why are they here today and what is the history of that illness that brings them there. And in some cases, it's chronic illness. So if somebody's coming in and they're getting their diabetes checked, so what I'm going to do is I'm going to say, okay, so what were your blood sugars over the last 2 weeks? And typically I have them keep a journal of at least their fasting blood sugars. And that's something that you might want to think about if you do have diabetics or people that have high blood pressure, that you do kind of keep an eye on what their trends are. And trending is important in vital signs and in lab work. We'll get to that a little bit later. The other part of that health history, now, if this is somebody that's totally new to me and I'm going from head to toe and just saying, okay, tell me all about you, then I want to know their past medical history. And those are things like maybe they have a history of asthma. Maybe they do have a history of hypertension. Maybe they do have a history of thyroid disease. Is that surgically? Is it a surgical thyroid hypothyroidism, or was it a medical hypothyroidism? And the difference is that they might have had a Hashimoto's thyroiditis, which is a hyperthyroiditis, and then the thyroid kind of burns out and causes hypothyroidism. But surgical hypothyroidism would be if they have a nodule or they have a cancer of the thyroid and then the thyroid is removed. Okay, so in that case, your parathyroid hormones will also be taken away. So just make sure that you have a good understanding of what their past medical history is. And I go into their GYN history if they're women. I also make sure that I know anything that's going on with GU for men. And it's important to just have a big picture of what their past medical history is. And that includes depression, anxiety, and their behavioral health history as well. I'd like to know what their surgical history is. So we'll go into, do they still have their gallbladder? Do they still have their appendix? And that is going to help me out in the end, because if they come in with abdominal pain, I already know that they don't have a gallbladder, so I'm not going to be focusing on a cholecystitis as a cause of that pain. Rather, I'm going to look for some other thing. If it's right lower quadrant, it's probably not going to be an appendix if it's already out, so it might be a colitis or a diverticulitis. So that past surgical history, again, helps you map out some of the things that you're going to be able to either rule in because, that's where the pain is. It's in that right upper quadrant where the gallbladder is. But, the gallbladder's not there, so it can't be that. So those are the kinds of things that help me to understand complaints and help me interpret my physical findings through the surgical history. Current medications are an absolute must, and I advise you that every time you see a patient to reconcile the medications. So, my patients go in and out of consults. So, in between visits with me, they may have seen their cardiologist and their neurologist. So, what's happening then is that the neurologist or the cardiologist might make a recommendation to me in that case. Hopefully, I have a note from them, but they may have just said to the patient, oh, increase your beta blocker, your metoprolol, or okay, let's increase your seizure medication. So, what I need to do is know what those medications are that they either increased or decreased, or if they've started them on something new. So always make sure that you've reconciled their current medications and the doses that they're on, because that's going to help you understand, for example, if they've stopped taking their beta blocker and all of a sudden their heart rate is up, what's going on. Allergies, again, are important, and this is going to be necessary for you as a prescriber, because every time I write a prescription, especially a new prescription or for an antibiotic or some other kind of prescription that I've never written for a patient, like a statin or an ACE inhibitor, I'm going to ask them what their allergies are. And make sure that you know what their allergies are before you give them that prescription. The other thing that I do is in my note, when I do write a new prescription, I always put discussed adverse effects of the medication and instructed the patient to stop taking the medication if they felt any adverse effects. And here's the thing on that. So for example, ACE inhibitors, something like a lisinopril, is associated with angioedema or a cough in some patients. So I always talk to them about angioedema and that if that would happen, and angioedema is a swelling of the tongue, and sometimes it closes off the back of the pharynx. So it could lead to respiratory distress. I tell them about that. I tell them to stop taking the medication. And in that case, I tell them to go to the emergency room. For the cough, sometimes the cough is kind of an insidious cough, and they come in and they go, I've been coughing recently, and I go back and I go, wow, I put them on an ACE inhibitor, 2 months ago, and they have this cough. And as soon as I stop the ACE, the cough goes away. So those two, for that reason then, or those two reasons, the ACE inhibitors would then go in under your allergies. So you would have to update your allergy list and put in that they either had, angioedema to lisinopril, or they had a cough to lisinopril. I hope that makes sense. Social and family history is important, and I know that you all do that extremely well. So I don't really have to go on to that in great detail, but just know where they are, where they live. And in my practice, I have people that are in and out of homelessness. We had a big lava flow in June, and many of my patients were actually displaced and homeless. It was very stressful for them. I could have used all of your help as psychologists because they were really, really experiencing a lot of situational anxiety. But it was important for me to know where they were, so that, had they lived in with relatives, or, were they homeless? And some of my patients do go in and out of homelessness. I serve a great deal of underprivileged, and so sometimes their background is and their lifestyle is very unsteady, and so I really try to keep an eye on them. Just the other thing that you might want to know, in my practice, I would say that about 60%, maybe even 70% of my patients have some behavioral health problem. And that is anywhere from anxiety, depression, bipolar, schizoaffective disorder, ADHD. So I have a spectrum of behavioral health issues. So it's an interesting practice. So moving on to the review of systems, I just want to let you know that when I'm doing that chief complaint and doing the history of present illness, I'm actually going through the systems that would be pertinent to their chief complaint. So if they come in and they say they have shortness of breath, then I'm going to think about all of the systems that would work with shortness of breath. So cardiovascular, I would do general examination like review of their fatigue, insomnia, those kinds of things. And then I would also look at the respiratory system. So what the review of systems is it's a series of questions, and it addresses each system moving from pretty much head to toe. One of the things that I find often is if I do the review of systems, I uncover overlooked health problems. So they're not going to tell me things if I say, oh, do you have a history of this, or do you have a history of that? They don't often remember that. But if I say, oh, do you have shortness of breath? And they'll say, oh yeah, I do, because of my asthma. But they don't necessarily disclose that in the medical history. So just the review of systems for me is kind of a nice backup to things. Focuses usually on symptoms or previous illness. Now remember, so far what we've talked about, the history and the review of systems, is all subjective. So this is all going on the subjective part of your SOAP note if you are SOAP noting, because this is what the patient is telling you. It's their perception of what's going on. So some of the things that I like to add in addition to actually going through the system itself, I'll say, are you taking any new medications? A lot of patients don't think that over-the-counters and herbals count, but I always make sure that I know what their over-the-counters are and the herbal medications that they're taking. And they'll say, oh no, I'm healthy, and then they'll give me 6 different herbal medications that they're taking, and I'll say, but why are you taking that? And they'll say, oh, because it improves my mood, or oh, it's for my nails, or oh, it's this, or my auntie told me that I should take it for my hair loss. So those count, and most of them are not FDA approved, and the drug interactions are not well known. So I like to know what they're taking. Things like St. John's wort, are important ones. The other thing I always look at is unexpected weight gain or loss. Weight gain would indicate something going on metabolically. For example, maybe some hypothyroidism. And weight loss is something that concerns me, especially if it's unexpected weight loss, because that to me is a trigger for cancer. So any kind of unintentional weight loss, general fatigue or malaise, just not feeling overall good is always something that I'm gonna look for a little bit deeper cause of it. I always say, how are your ears and hearing? People that have impacted cerumen do have decreased hearing. So if you send them to the PCP to get that taken out, and they hear much better. Any signs or lesions in terms of skin lesions? That's a good question, because you don't necessarily see their abdomens or their backs or their legs if they have pants on. I always ask them about their heart and their circulation. Do you have heart palpitations? Do you ever feel like you're skipping beats? Problems with your lungs or breathing, as shortness of breath. And then when you do shortness of breath, always, especially if they have asthma or COPD, if they have heart failure, you always want to know if they have shortness of breath at rest or if it's with activity. So shortness of breath with rest is a harbinger for difficulty, okay? And that's called dyspnea. And usually if you're talking to a patient, they are short of breath, you can hear the interruptions in their voice patterns because they're breathing. So that's something that you really need to refer them back to their cardiologist or refer them to their PCP. But as psychologists, you're going to have to differentiate that between, is it hyperventilation or is it shortness of breath? One of the things that you can do is listen to their lungs, and then we can talk about that in a minute or later on. So always ask about their lungs and breathing, particularly because a lot of psychiatric or mental health issues are associated with breathing, like fast or slow. Any change in bowel or bladder function is always a good question to ask, because if they're taking opioids, they're going to be constipated. If they're taking some other kind of medication, or if they have bowel disease, they might have diarrhea. And you always think about bladder function. You can also ask what color is their urine. So if they are sick and they're not drinking, what color is their urine? If the urine's very dark, that means they're dehydrated and they're not drinking enough. And I always ask about their sex life, and that's kind of a very it doesn't come with any surprises. Usually I just say, how are your bowel and bladder function? And then I go, and how's your sex life? And usually they're pretty good about answering me. And some of them might be a little surprised that I ask that, but I always do. And in many cases, they're appreciative, especially the men, because that's something that they don't talk about too much. Okay, now as we move into laboratory data is objective data, all right? So now we've moved away from that subjective section. Hopefully we have enough information through our history and looking at our past medical history, our surgical history, the social history, and then behavioral health history, and then review of systems. Are there any questions before I get into lab data? All right, I'm going to take that as a no. And then we're going to go into the lab data. So as psychologists and as prescribing psychologists, I would definitely want to make a connection with the PCP of your patient. Because if you have that connection with the PCP, then you're also going to get on the lab slip, so that you are going to be able to see the labs that the PCP is ordering and reviewing with the patient. You should be, as a prescribing psychologist, ordering your own labs for certain things, but it's important too that you follow some of the labs that the PCP is doing. And so what I would do is just make sure that on my orders, I always put other providers who want information. And that way they get an electronic copy of the labs as well. Just make sure that your patient knows that you are you're sending labs to other people, and make sure it's okay with them. Okay. I really super appreciate the psychologist's notes and the neurologist notes and the cardiology notes, because that helps me get an understanding of what's going on. And sometimes they do labs that I don't do, and so it's good that I see what they're doing. And it's good that we don't have to repeat or have repetitive labs in the same lab kind of period. Okay, so let's think about why we do laboratory labs. And I know that Randy went over this, but this is just from my perspective. I do serial labs, and the reason I do serial labs is because I want to look for highs and lows, and I want to look for trending. And that's important because I could have somebody who has an elevated ALK-Phos or AST, ALT, but it's just kind of over the border of the higher range. And in that case, if I only have one data point, then I'm not going to worry too much about it. But at the second time, if that trend is going up, if the ALT, AST, or ALK Phos is trending upward, then I'm going to want to know a little bit more about what's going on. And the other thing that you can do based on looking at your labs is ask questions about what they're doing, okay? So we want to look for highs and lows, and we're going to look for trends. The other thing I want you to understand is the sensitivity and specificity of a lab. So, for example, if someone comes in to talk to me and they say, "Oh, I have this this pain in my hands," and I go, okay, so has it always been there? Did it just start? What have you done to help it? And you know, I kind of look at it. There's, the hands are not inflamed. The joints are normal size. But I'm thinking in the back of my head, why would somebody have bilateral hand pain all of a sudden? Well, have you been using your hands for anything specific that, you know, like, for example, yoga? You know, sometimes people start yoga and they're doing, you know, downward dog, or, you know, pushing on their hands and their wrists a little bit more than they ever had, but it's bilateral equal weight. So in that case, I would say, oh, okay, it's probably from yoga. But what if they don't do something like that? Then I think, okay, well, could it be some kind of inflammation? All right, why sensitivity and specificity in that case? So I'm going to do something called a C-reactive protein. I might do an ANA titer. I might do a SED rate. Those are inflammatory markers. And those inflammatory markers they're very, very sensitive to inflammation in the body, but they're not specific. So even though I would have an ANA titer elevation, I don't know why it's elevated. That means I have to go figure out some more stuff. So I might put in a rheumatoid factor the next time I see the patient. Okay, so sensitivity is, it's responding to something that's going on, but it's not specific. So now let's look at specificity. Specificity is something that it's elevated and you know why. And an RA factor, for example, would be very specific to rheumatoid arthritis. And an elevation in RA would make me very suspicious that they had rheumatoid arthritis. Troponins are another one. Back in the day, we used to look at some of the CPKs and the MBs to decide whether or not a patient was having a heart attack. Today, what we're doing is we're really looking more at something called troponins. And those troponins are an enzyme that's released. And what happens is it's kind of the troponins leak. And you can see a trend in elevated troponin. And that has been linked specifically to myocardial injury. So just when you think about your labs, you want to know, are they sensitive or are they specific? Okay. Again, now when I look at my laboratory data, what don't I have? What don't I have that I need to have, that I need to follow up with? So I always look at the gaps. So for example, if I'm looking at a hemoglobin or probably a CBC, complete blood count, I want to look at those red cells, and I might have something that looks like it's an anemia, and then what we would do is we would maybe do an iron level, ferritin levels, and or folate, depending upon what way the MCH is going, if it's low or high. So those are the kinds of things that are gaps. Okay, hopefully that helps. Okay, so the other part of the labs is it does helps you diagnose. So it fills in some of those gaps that are question marks in your history or your physical exam. It's confirming the hypothesis or diagnosis that you're making to either rule in your hypothesis or rule out. So when I teach my doctoral students, my nurse practitioner students, I talk about differential diagnosis, and I talk to them about developing hypotheses. So whenever you're thinking about a problem, it could be more than one. So always make sure that you're not closing too early, like, oh, it's got to be this or it's got to be that. Because in shortness of breath, for example, I could give you 5 differential diagnoses, and if it's a new patient, I'd have to work through every one of them. And my laboratory data is going to help me with that. My history is going to help me with that. And my review of systems is going to help me with that. And we're going to do imaging, which will also help me. So a hypothesis to me is just that. It's, what do I really think it is? What am I looking at? And then I need to use my laboratory data and my diagnostic data to fill in the gaps, okay? So when I look for diagnosis, and you probably all do this yourselves, because as you're talking to someone, you're making up your hypothesis as you go along. So, you know, is this anxiety, or is this, you know, a manic phase? It's just general anxiety disorder? Is there anything that goes with that that would make it something that's post-traumatic stress? So you're already doing all of that. And so you know how to do that. I'm just pulling it into a medical model that is more medical than behavioral health. So in terms of how I think in stages. So what's the initiation of the diagnosis? So, and the strategies there is kind of spot diagnosis, self-labeling, presenting complaint, and the pattern recognition or triggers. And we talked about that when I talked about the chief complaint and history of present illness. Then I'm going to go and I'm going to refine my ideas, okay? Remember we talked about somebody having aches and pains. So is this a general cold, or is it a flu? And do I have to think about flu? So I'm going to refine my, my diagnosis, and I'm going to do rule outs, and I want to do it in a stepwise fashion. The other thing that I think about is probability. One of the things I like to ask my students is the probability of zebras in Kansas. That's kind of the analogy I use. So sometimes when students are new, they have these outrageous diagnoses because they looked them up, and okay, this shortness of breath could be associated with, you know, for example, pulmonary interstitial fibrosis, which is not that uncommon. But if it's a cough and sore throat, it's probably not the right diagnosis, and the diagnosis would probably be, the probability of it would be 1%, whereas a cold upper respiratory tract infection would be a 90% probability. So that's kind of what I'm trying to get there when I say probabilistic reasoning. You know, what is the probability of this being the diagnosis? The pattern recognition fits. And that's important because remember that in that initial early diagnosis, in that history and physical phase, in that HPI specifically, you're looking for patterns. And then when you get to the refinement, you say, wow, the clinical pattern or the associated findings fit with what this diagnosis is that I'm thinking about. And then you need to define that final diagnosis. You have a known diagnosis, maybe you have asthma, and maybe you're talking about an asthma exacerbation. What further tests do you need to order? That's where you're filling in the gaps. And sometimes it's a test of treatment. So let me give you an example. I had a patient come in, and he has really bad COPD. That's chronic obstructive pulmonary disease. He has very bad COPD. He's seen by a pulmonologist. He's seen by me. He's probably on at least 4 medications to manage his symptoms so that, you know, he does breathe. So he has, you know, an inhaler, he has a nebulizer, and he has at least a combined nebulizer with 2 different types of medications, a long-acting and then the other thing that he takes is Montelukast, which is a pill. So now I'm like, okay, he's sick. He's coughing more. He's got more short of breath. He's more short of breath. And I listened to his lungs. His lungs are always bad. They always have bronchi and wheezing in them. So the lung auscultation is not really helping me. But he's increased his coughing. He doesn't feel good. So I'm going to treat him. Okay. I'm going to treat him with maybe an azithromycin, which is it's an antibiotic, a macrolide. And so what I'm going to do is tell him, take this. It's a 5-day treatment. And if you're not better in 3 days, then I want to talk to you again. Come back and see me. So that's a test of treatment. So if he comes back and he's still not doing well, then I'm going to get a chest x-ray and maybe see if he has a pneumonia, and then work from that angle. And maybe that azithromycin that I gave him wasn't the right medication. So I might start him on maybe an amoxicillin. Okay, so that's test of treatment. And test of time is similar. All right, well, let's watch this for a little while. Let's watch it for a couple more days. If you feel worse, then we'll do something. If you feel better, then we know that it was a virus and it wasn't a bacteria. And then sometimes you just don't know what it is. So you can put a very unspecified diagnosis in there. Okay, so any questions on your hypothesis and hypothesis generation and being able to refine that into a diagnosis? You should be doing that pretty much all the time in your own practice. But what we're doing here is just using it in a medical model. Okay, great. Yes, thank you so much. I see it. 70% of you said yes, and I think so is 27. Perfect. Thank you so much. So we're doing good. We'll move forward. All right, hold on here. Oh. Okay, so now what I want you to think about is a problem list. And based on the patient's history, we already got in some of that chief complaint that you may actually now put in as a medical problem. You now have a list of problems. And this list of problems for me is important. So I always go back to my list so that I know what I've treated patients for, what they've been treated for by other providers that maybe were before me, or by specialists. So it's important for me to have that list that I can go back to and I can add to. Some people actually take things off their problem list. Like I kind of tend to hoard my problems because I like to know that there was a history somewhere of something. So, and sometimes it's just a good reference. Okay. So the problem list is a prerequisite to clinical management, to patient support, for doing research, doing discharge planning, and also for coding. I don't know how much coding you'll be doing once you're prescribing. Yeah, and you'll probably still be doing your own coding. So like if you have somebody with bipolar disease, you're gonna code it. And you're probably doing the DSM-5 coding, where I'm doing ICD-10. So I'm not sure which coding you're more familiar with, but you can code like bipolar disease as an ICD-10 and a DSM-5. So anyway, coding is important, and you're not going to get any payment if you don't code correctly. So that comes back to me. So my coders, when they look at my charts to code to collect money, periodically they'll say, "Oh, this doesn't seem to be going in under this code. Would you change the code?" For a long time, I was using an E78.2 or 4 for hyperlipidemia. And all of a sudden, the insurance companies are not taking it in that code. I think it was E78.4. And so my coder, my biller coder, would send me a text and say, "Hey, can you put this under another code?" And then typically you can find another code that's similar, or that's close enough to what you're actually hypothesizing and diagnosing. So just know that coding becomes important from a perspective of billing. Okay, and the patient support, that's really important as well, because I do a lot of referrals, and I do a lot of referrals, for example, to psychologists. I do a lot of referrals to physical therapy. I do referrals to dietitians, especially for my diabetic patients, and I do it for my new patients, and I do it for my old patients. I do it with my older patients, and I don't mean chronologically old patients. I mean people who have had diabetes for a number of years. I will actually do, I might send them to a diabetic manager, a dietitian, because their hemoglobin A1Cs are not improving. And they keep telling me, well, I'm eating the right thing, and their hemoglobin A1Cs are not budging. So anyway, so patient support is important, and finding good patient support is necessary for them. And that's going to help. The problem list helps you with that. Okay, so now we're at SOAP charting. So you had your subjective data, and that's what the patient is telling you. And then objective data is what you learned from the physical exam and the laboratory data. We haven't done the physical exam yet, but that's going to be an objective data. So when you look at assessment, that's what your diagnosis or problem is. And then plan is what you do. For me, there are 3 parts of the plan, okay? And I think that I teach my students this all the time, because they want to make sure that they have documented what they're doing. And that is there an RX? And when I say RX, that's a treatment. And an RX could be a medication, or an RX could be an instruction to do something. So you definitely want to do the treatment, or RX. The second one is, what's the follow-up? When do you want them to follow up with you? So I gave the example of the guy with COPD who has the cough that's exacerbated. I've given him an antibiotic, and I'm going to put in my note, patient to return to clinic if he's not feeling better in 3 days. And then the last thing is, what did you teach them? So your note for a plan should include the treatment, the follow-up, and the teaching. Okay? And that's going to cover you. But the other thing is, before a patient comes in, before I go in to see a patient, I always pull up the note from the last visit, and I always look for labs, just to make sure that I haven't missed any labs. And I always go back and look for my diagnostic tests. So for example, if they had that, the hand pain, I might have done bilateral x-rays of the hands just to see if there's anything in there that I need to know. And then I want to make sure that I follow up on that. Okay. So it's important that you know what to do with your follow-ups. Okay, so that's pretty much this SOAP note. And you've been doing the SOAP note, is that correct? I know that I think Judy told me you were already doing SOAP notes, but you know the subjective objective.
Yes.
Okay, perfect. Okay. And again, you already know pretty much how to do that in your own practices. Okay, so I think we have some time now for just to continue with the points in the physical examination, and then after that we'll take a break. Okay, so observation. I think as psychologists, you probably do this way better than most other providers, because you're always looking out for distress, or you're looking for the appearance of someone. And I think that as a nurse, I was taught as a nurse to be very observant. So, in an ICU, or in an ER, or even taking care of patients on a medical floor, my observation skills were always tuned in. And so what you're doing is looking at the overall state of their health. So I can see someone and I go, oh, they're sick, and they really need something. I can see that they're sick. I can see it in the way they look, the way they sit, the way they act. I can see it in their eyes. I can see it affectively. So that's an important thing to document, even though you're looking at it. So in my note, it's going to go under my general exam findings, and I'm going to say patient appears sick, or patient appears well, and no acute distress. So look at that overall state of health. I can tell some of my patients that have lost weight, and they come in, I haven't seen them for 6 months, and I go, so you look like you lost weight. Have you been trying? And remember, if it's unintended weight loss, then I'm going to go in and say, ooh, well, what's going on with that? Are you eating? So look at that overall state of health. Look at their the way they look, the way their bodies look, their habitus, for example. And then level of consciousness is another observation. Again, this is something that you would be very keyed into as psychologists. And for me, I can tell some of my patients who are seeing psychiatrists, some of them I think are over-medicated, and they're very flat in terms of their affect, but they're quite able to, their level of consciousness has not changed. So it might be that they're slowed in their cognitive responses, but they're still awake and alert and oriented. Okay, so to me, a level of consciousness change is something that is different. They're more agitated. They're less agitated. So just kind of watch that. Signs of distress always. And what would you think are signs of distress? It's hard to talk to a
psychomotor agitation.
Yeah, that's great. So psychomotor agitation would be a sign of distress. Anything else? Anybody know? Increased respiratory rate would be a sign of distress for me, because, shortens the breath. Remember, we talked a little bit about that dyspnea. Dyspnea would be a sign of distress. Those are the kinds of things that you're looking for. Height and build, we already talked about. And in that height and build, you want to look at, is there barrel chesting, or, again, that the importance of weight and how they look. Okay. When I think about weight, I think about BMI, and the insurance companies love BMI. Because they can categorize somebody in, obese, or overweight, regular, underweight, the problem is that BMI, especially in people that are have big muscle masses, some of the guys that aren't even lifting weights, but just have good muscle mass, their BMIs are going to be in the overweight to the obese category, and that's because of that muscle weight. So I always document it that they lift, or they have big muscle mass, even though I do document my BMI on every patient. Okay, skin color and lesions. So skin color is important to look at. It's particularly difficult to see it in changes in skin color in darker skin. So I have a lot of Hawaiians, Filipinos, Asians, and so their skin colors are different. So I have to kind of look at different markers for that. So I look at the eyes, the sclera. I look at their fingernails, so that I can make sure that their color looks good. Lesions are something also that can be hidden. So, for example, if somebody's cutting, or somebody's been burned, or somebody's abused, you might not find that. But hopefully, in that review of systems, or, the overall state of health, when you're looking at them, you look like you're having difficulty. And remember, I said that review of systems sometimes pulls out information that they weren't expecting to tell you, or they forgot to tell you. And so sometimes I find out about abuse, or I find out about cutting or lesions, just because I'm more observant, or I'm asking more questions in that review of systems. So you're not going to be able to see underneath clothing. So you're going to have to be very observant, right, with what you're trying to find out about that patient. Dress, grooming, and personal hygiene is an important one. And I like to tell this story because I had a preceptor one time, and I'm not kind of throwing her under the bus, but I was pretty young clinician student. I was a student, and I was in this practice with a nurse practitioner, and a young woman came in, and she was probably in her mid-20s, and she had a baby with her who was maybe 18 months old, 12 or 18 months old. But he was a chubby dude. He was just a real chubby kind of child, and he was sitting in a car seat that was way too small for him. And the mom herself didn't look like she'd combed her hair, even changed her clothes that morning before she came to the appointment. And her reason for coming to the appointment was that she wasn't feeling well. She had, probably, a cold or a flu or something. I don't remember. And when I took her blood pressure was like 170 over 90 to 100. And that concerned me. And so when I went out to talk to the preceptor and present my case, and I said, she's probably got an upper respiratory infection. And, but what concerns me is this elevated blood pressure. And then the nurse practitioner went in to see the patient, and she kind of said, okay, well, you have an upper respiratory viral infection. We're not going to do anything. Get rest, go home, sleep, whatever, stay hydrated. And when I came out of the room with her, I said, why didn't you address her blood pressure? And she just kind of said, do you think she cares about her blood pressure? Look the way she looks. Look at the baby in that undersized car seat. And I went, wow. So that was just kind of this value judgment that this nurse practitioner made that that was kind of off the wall, and it was based on how the patient looked and how she took care of her baby. And so she didn't want to address the blood pressure issue. So being me, I go back in there and I talk to her about her blood pressure being elevated, and told her that go to Walmart and, you know, check your blood pressure every day. And if it's too high, then you need to come back or find yourself a new PCP. But anyway, that's kind of a goofy story, but we make a lot of assumptions based on our observations. And in that case, I was really very worried about her blood pressure. I couldn't write a prescription for it, so I only told her to, you know, decrease her salt intake and try to lose some weight and take her blood pressure every day. And so that's just the story of dressing and grooming and personal hygiene. And I think that the same goes for body and breath odors, but breath odors are important because you can definitely know if they've been drinking alcohol. Sometimes you have a fruity breath that goes along with excessive sugar. So that's important. And for me, body odors are there because I have homeless people that don't necessarily shower every day. And then posture, gait, and motor activity is also important, particularly if you're suspecting some kind of neurologic problem or, you know, they've had a stroke in the past. You want to make sure that you're looking at their gait, their posture, their balance. Okay. So observation is a very, very useful tool. Let's see. Okay, I think what we'll do is we're going to do the vital signs before we take a break, because when we're finished with the vital signs, then I have a case study that I want to go over with you. Okay, so people say that there's actually 5 vital signs, and they've included pain as a vital sign. So what we're going to do is we're going to just kind of go through these. And hopefully then when you take a break, make sure that you are using your cuff and see if you can come up with some blood pressures, maybe on a friend or a loved one or someone. First of all, when we start out with blood pressure, you've got to have the right cuff, the right size cuff. If you are using a normal size cuff on somebody who has a very large arm, you are going to get a bad reading. It's going to be hypertensive. So you've got to find the right cuff. In my clinic, we have 4 different size cuffs, and I actually have a thigh cuff that I use sometimes on my very, very, very big obese people. So just so you know that you need to have the right blood pressure cuff. You can't do, you need to use a child cuff if you've got a little skinny arm, and you need to use a bigger cuff for a thick arm. So that's number 1. Okay, so what's blood pressure? Blood pressure is the pressure exerted on the walls of the artery by the circulating blood. Systolic pressure is the maximum pressure in an artery during a heartbeat. And so we could say that that's basically systole. So during systole, there's a contraction, and that's the maximum pressure in that artery during that contraction. That's the top number. The bottom number is called the diastolic pressure, and it's the lowest pressure in the artery between beats when the heart is at rest. The reason that diastolic pressure is important is that you definitely want that pressure at rest to be low. If it's high, that means that there's no respite, there's no interval that the arteries are relaxed. And that's a sign of, it could be diastolic heart failure. So systolic pressure is the pressure pretty much when the heart is working on contraction, systole, and then the diastolic pressure is when it's resting. You don't want a high resting diastolic pressure. Okay, so if that number is above 90, then your patient needs to probably be treated. Okay, so how do we take that blood pressure? So I always ask them, what's your normal blood pressure? Or I know because it's already in my EMR. And actually my my medical assistant does all my blood pressures for me. However, I'm an old school person. I don't like those little and wrist cuffs or forearm cuffs that are kind of electronic. And sometimes I actually have her do cuff pressures, like the pressure that you're seeing in this picture. If I don't like the blood pressure, I always retake it and I always document it. So I document what the original blood pressure was, and in my note I say retake blood pressure was blah, blah, blah. I want to know why blood pressure is high at this visit and it wasn't at the last visit. And I will just probably say something like, just came in, is excited, is having a lot of stress this visit. And so document why that blood pressure is a little bit higher, okay? Trends say that the next visit, if that blood pressure remains high, then I'm going to start treating it, okay? But people have high blood pressures for a lot of reasons. Okay, so here's the classifications basically for adults. Hypotension is less than 90 with a diastolic of less than 60. We'll talk about Randy in a minute. Normal is usually between 90 and 110, and then diastolic is 60 to 79. Your prehypertension is 120 to 139 or 80 to 89. You know, there's a little bit of variation to this. So I always say to my patients, I want your blood pressure under 140 systolic, okay, and I want your blood pressure under 90 diastolic, okay? So those are my goals. The other part of the goal for me is if I have an older patient, say they're in their late 70s, early 80s, I am not going to worry too much if their blood pressures are 140 over 90. I'm not going to bring them down much lower than that. And the reason why is because their arteries are probably, they already have coronary artery disease just by virtue of their age. And I don't want to lower it because they might have postural hypotension. They're already at risk for fall. So I usually will keep them up a little bit higher if I won't treat them if they're borderline, like in between 140 and 159. Stage 2 hypertension, for me, anything over 100 is an alarm. So I will put them on a blood pressure medication. I'll bring them in a couple days later. So maybe they'll come see me Monday. I'll say, come back and just get your blood pressure checked on Wednesday. And then then if it's still up, I'll probably treat them if it's over 100. If it's up in that stage 1 category, what I'll do is I'll just kind of watch them for their next visit and then tell them to bring blood pressure measurements in or come into the office and get their blood pressures measured. And, you know, I like to tell them to go see the firefighters. Sometimes the firefighters will take their blood pressures at the fire stations, or go to Walmart or the pharmacy. They always have blood pressure cups there, and then record them and bring them back to me. Anytime I prescribe hypertensive medication, I make sure that I bring them back in 2 weeks so I can check their blood pressures. Okay, so what influences our blood pressure? There's a lot of things. Genetics, age, I already talked about. Blood volume. So blood volume is important. People that are dehydrated have low blood pressure. People that have lost a lot of blood have low blood pressure. Stress is going to increase blood pressure. Exercise is going to increase blood pressure. Medications could either go up or down, depending upon what they are. Nutrition, what's their protein look like? Atherosclerosis, we know that it will probably increase blood pressure. Smoking increases blood pressure, and alcohol kind of maybe can lower or increase it, okay? So it's important to know, their background. Okay, so are there any questions about blood pressure? You know how to take a blood pressure? So you're going to put that cuff on the upper arm, And then you're going to put your stethoscope right on the brachial artery. So find that brachial artery, put your stethoscope on, and then pump it up to probably 20 to 30 millimeters of mercury higher than the blood pressure that they tell you is their normal. All right. Now you're going to listen and slowly release that and listen for the first pound, the first beat, and that's the systolic pressure. So that's the contraction against the highest pressure, and then you listen to the sounds until they fade away. And the last one that you hear at that number, that's your blood pressure, diastolic blood pressure. There's a lot of variations with that, like in ICUs and pulse pressures and stuff like that. But I think that just knowing how to take a blood pressure and how to take it correctly is good for you. And do it, especially if your patient is anxious. They have, that going back to that loss of consciousness again, behavioral changes. When I say loss of consciousness, I think of behavioral changes. So anybody that looks suspicious to you, they're sick, take their blood pressure. They're not acting right, take their blood pressure. They say they have a headache, take their blood pressure. They haven't been eating well, take their blood pressure, so that you have some kind of gauge for what their blood pressure is. And, if you're prescribing, I think it's a really good idea for you to make sure you take their blood pressures at every meeting with them. Same with heart rate. I think that that's also a good one it's easy to do. And you can just do it with, if you get yourself a little pulse ox, the little pulse oxes you slide it onto your finger, and the pulse ox will give you the percentage of oxygen that it's calculating off your nail bed, but it also gives you a heart rate. So in that case, you don't even have to find the radial pulse. You can just get their heart rate off of the pulse ox, and they're little plastic. They almost look like little alligator things, little alligator clips, but they're perfect. And then you have their heart rate and their pulse ox, their oxygen percentage. Okay, so heart rate characteristics, you want to know what the beats per minute are, and normal should be 60 to 90. Remember that anybody that's on a beta blocker would possibly have heart rates under 60. Some cardiologists want their patients under 60 because they want to slow that heart rate down. They'll put them on a beta blocker so it slows it down and increases contractility. Okay, so 60 to 90 is okay. You want to look at rhythm. Regular, is it regular or irregular? Now in this case, you have to touch them. If you want to find out whether a rhythm is regular or irregular, you have to touch them. You can either listen with your stethoscope, or you can actually just do a radial pulse. Your choice. If it's irregular and the heart rate is between 60 and 90, you're in good shape. If it's irregular and the heart rate is greater than 100, send them to the emergency room, because you have an irregular heart rate with a very, very fast beat. Okay, so they're having difficulty with filling, and they could have difficulty with shortness of breath. They might have some heart failure going on, so that's important. Bounding just means that it's full and it's boom, 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 and you can feel that bounding pulse. And it might be related to the fact that, hey, I just exercised, and you can do that after you exercise and feel it. Thready is more worrisome to me, because thready means that it's kind of thin in there. It might be dehydration. It might be blood loss. Something's happening. Okay. And then go over here and look at what influences heart rate: exercise, drugs, alcohol, smoking, caffeine, and heart size. Okay. And that's what I worry about. Heart size. If you have cardiomyopathy, then you might be in trouble with that very fast, irregular heartbeat. Just give you a little story. So last week, I was in with a patient, and my medical assistant knocked on the door, and she said, "I have to pull you out. I have an urgent phone call from an anesthesiologist that he wants to talk to you." So I go out of the room and I get on the phone, and the anesthesiologist is the anesthesiologist who was with my patient who just had his cataracts removed, or one cataract removed. So the ophthalmologist removed the cataract, and the anesthesiologist was there. And this is a patient who's probably 58 to 62 in terms of his age. And the anesthesiologist told me that his heart rate became very irregular, and his heart rate was 140. So I said to him, "Okay, so is he awake and alert?" And the anesthesiologist said yes. And I said, "Is he having any shortness of breath?" And he said no. So I said to the anesthesiologist, "Well, if his heart rate is irregular and it's over 140, I want you to send him to the emergency room to make sure that, to document what his heart is doing, number one, and number two, to slow his heart rate down. And three is to find out whether he had a heart attack or not." That would be the troponin, right? Okay. The anesthesiologist said, "Wow, that's a really good idea." So anyway, that's what happened. So the patient did go to the emergency room. I got the note back, and basically he was in atrial fibrillation with a rapid ventricular response. They call that AFib with RVR. And they slowed his heart rate down with some cardiazem and did the EKG, and they did a troponin, and his troponins were negative. So that meant he probably didn't have a heart attack. So my next step for this, my patient, is to send him to the cardiologist to find out why he went into atrial fib with RVR. Okay, that's the story. Hope my little stories are helping you. Okay, so temperature. You may not have a thermometer in your office. There's no more mercury, obviously. There's no more even under the tongue. Some people are just going across the forehead and getting a temperature. We have an ear a thermometer probe. So you do want to make sure that you get a temperature, if you can, from somebody who looks really sick. Okay, and oral is 98.6, give or take 1 or 2. And then tympanic is usually a little higher. And then axillary is going to be hard to get unless you have like some kind of a probe, and rectal you're not going to get. But just so I put them in there just so you know that there are differences in temperature based on where you're getting the temperature. Okay, respiratory rate. We talked a little bit about this already. So you're looking at rate, rhythm, depth. So rate, how many times a minute are they breathing? People that are anxious breathe fast. Their rhythm should be regular. There are patterns called Cheyne-Stokes that they increase their respiratory rate and then decrease their respiratory rate, and then they have an apneic event. It's sometimes interesting when you have people that say, my wife or my husband says, I stop breathing in the middle of the night, but then I wake up and then I'm breathing again. Those people need a sleep study. They probably have sleep apnea. So that's important. The depth is shallow and rapid. And remember, if it's shallow and rapid, they're probably trying to blow off something like their CO2, or they can blow off their CO2. So, for example, in hyperventilation syndrome, it might be very shallow and rapid because they're worried, they're scared, they're in panic attacks. You might see shallow and rapid. But you might also see shallow and rapid in diabetic ketoacidosis, because what they're doing is they're trying to kind of blow off some of their CO2. And then look at the effort of their breathing. Does it look like they're having trouble breathing? And then you would think about sternal retractions. Just the effort of breathing looks bad. And usually this is something that I see with my COPD patients that are in exacerbation, or my asthma patients who are having an exacerbation. Okay, so watch what they're doing. Okay, so here is my case study, and I think we're good. So let's kind of take a break here. I know I'm a little off. So we'll come back in about, what do I have, 8 and 15 minutes? Is that what I put in there? So go get something to eat, get some hydration, and we'll come back with Randy, okay? And actually, I'll keep Randy up so that you can look and just read his case, okay? And then we're going to talk about what we're going to do with Randy. And Randy is a real patient, by the way. Okay. And it's not Dr. Randall. Okay. See you in about 15 minutes. And I've known him for about 3 years. He comes in and out sporadically, so sometimes I'll see him a lot. When I originally started seeing him, he had a terrible back pain. He was opioid addicted. And since that time, he's gone off all his opioids. His back is better. We've kind of treated him at a pain clinic. He's gotten injections, but he's actually doing much better with his pain. He's 68 years old, and he has a history of profound depression for many years, but he doesn't take any medication. He has a psychiatrist in California, and he's had this psychiatrist for years. So he's back and forth on the phone with his psychiatrist pretty regularly. 3 years ago, right after I met him, Randy's partner of 30 years died suddenly of a heart attack, and Randy found him on the floor in the morning. And this shocked him and overwhelmed him. And since that time, he became a recluse. He doesn't have any friends or contacts. And he always tells me the reason he's in Hawaii was because of his partner. He didn't want to move to Hawaii. He wanted to do something else, but he wanted to make his partner happy, and that's why they moved to Hawaii. The only real contact he has is with a housekeeper and a yard service company that maybe stops in every month or so to cut his grass and do some weeding and things like that. And he does have 2 dogs, and the 2 dogs are his partner's dogs. So he kind of has some responsibility toward them. Recently, Randy was diagnosed with an umbilical hernia. He had some abdominal pain. He was referred to the surgeon, and it was incarcerated. And that means that the hernia pops out, but you can't put it back in, and it stays out. So it's a dangerous situation for the hernia. And that led him to go to the emergency department. So he was scheduled for surgery to repair the hernia. And on the day of the pre-op visit with the surgeon, he had a cold. And so the surgeon said, well, we're not going to do the surgery. And Randy was instructed to come see me for treatment. So Randy did not come for a couple days. And when he came, almost a week after the surgeon's appointment, his cold was no better. Okay, so how will we approach this patient? So what do we know already? Anybody want to chime in here? All right, so okay, what we do know is that he's got a history of depression. It's a pretty profound history of depression. He has an umbilical hernia that needs to be repaired. It was incarcerated. So it's kind of like we really want him to get that done, but he can't get it done because he's sick right now. Okay.
I just wanted to ask, do you see the comments on the chat board?
No, I don't.
Okay. I was wondering about that because it didn't seem like you might be seeing people's responses over there.
No, I didn't. Wait, let me see if I can find them. Aiden, how do I find
Yes,
those?
there is a chat bottom icon at the bottom of the page, or maybe for you at the top of the page.
Oh, there they are, the chats.
Yeah.
Okay. Sorry.
Are we still reaching the poll part, the question part?
Let me just see. Hold on.
Maybe it's easier to just talk. I mean, we don't
Yeah,
have
it's kind of nice if you kind of, you know, kind of interact with me. I really like that. I feel like I'm in some vortex.
I had a question. I was wondering when Mr. Randy come to see us, like what is the purpose of his visit?
Oh, to me?
Yes.
So the reason he came, his chief complaint was, remember, the surgeon said he's not going to do surgery, so go see your PCP to get your cold symptoms taken care of, basically is why he came. Okay? Does that make sense? So but he waited for a week to come see me.
Okay.
Okay, and because remember, he's a recluse, he doesn't want to come and see me if he doesn't have to, and he was a little, he didn't want to do that, okay? And so that's why he waited. He did tell me later, and after as the story unfolds, he trusts me. Randy trusts me. He doesn't trust a lot of people, and so he did come because he knew he wasn't getting better. All right. So what we know is that he was sick. I asked him that day, what information do you need? What more information do you need? I asked him, Randy, do you have a fever? And he said, no, I just took it at home and I don't have a fever. Okay. So do you still feel sick? Yes. Do you feel any better? No, he hasn't gotten better. Did you get worse? He said, yes, I'm feeling very, very weak. I haven't eaten. He hasn't had anything to drink. Okay. So he's getting more sick and now he's not eating well. All right. And he feels muscle aches and pains everywhere. Okay. That's what he told me. Remember, I have to go through like, what is the pattern of the characteristics of what's going on with him. Right. So I'm like, okay, he's dehydrated. He's, he looks, okay, let's go to observation. He looks sick to me. I know he's sick because he looks sick. He looks like he's lost weight. He looks sick in his face. He's acting sick. Now remember, his affect is always flat. There is never any innuendo, there's no variation in his voice. It's always flat because of his depression. So anyway,
I guess I want to know about his, if he's lost weight, it's because of things like nausea, if he's been feeling ill, or if it's because of lack of hunger.
Yeah, because he hasn't
like appetite.
eaten. Yeah, he's not eating and drinking. And then I said, well, how long was that going on? And then he told me, in his little flat voice, he told me, well, I ate a little, he drank a little bit today. So that was that morning. He drank a little bit. He wasn't vomiting. He had no diarrhea. Okay. And so, all right. So now I'm looking at him and he's lost weight probably because he hasn't been eating. All right. So the next thing I do is I get my MA, my medical assistant, and I said, let's take his temperature. Because when I touched his arm, he felt a little warm to me. And his temperature was 101.8. His blood pressure was 70 systolic over 40. Okay? So, and his heart rate was a little bit elevated. It was close to 100.
70 over 40, how is he able to walk?
Exactly. Okay. So here's the HPI stuff that I wanted to just review with you. Okay. So incarcerated umbilical hernia requiring surgery, 7-day history of a cold. And then I asked him, do you have a fever? He said, no, remember. Do you have a cough? And he said a little bit of a cough, but it wasn't productive that much. But when he did get something out, it was white or yellow. So that's not too much of a concern to me, right? If it's white or yellow. I worry when it's green. Do you have muscle aches? He said, yes. Are you sneezing? He said, no. Do you have a runny nose? He said, no. Have you taken anything to feel better? He said, no. Do you feel any better or worse than it started? Remember, I said he's feeling worse. And have you been able to eat or drink? And he said he just started drinking a little bit today. So here's his temperature, 101.8. His heart rate is 96. His blood pressure is 78/40. He's profoundly depressed. So he could be one of your patients, because what did I say? He came because he trusts me, and your patients trust you. Okay, so question 1, what blood pressure is a normal range for a 68-year-old man? Oh, I should say, Randy's blood pressure is normal range for a 68-year-old man. Was that true or false?
False.
It's false, right. His blood pressure is way low, and it's a scary low, okay? And his heart rate is gone up to 796. So he's trying to adjust his cardiac output because his blood pressure is so low, okay? I'm sorry, his blood pressure was 78/40. All right, now, knowing the normal range of blood pressures, what's your next step for Randy? And I want you to select all of the things that apply. So just call them out. What do you want to do next?
Retake the blood pressure
Yep, absolutely.
and then document it, and then,
No, well, but you don't want to document it as it's written here,
right,
right? You want to document your new blood pressure.
right. And,
Okay,
and put that it's been taken a second time.
correct. Okay. What else?
I would also want to know if he was dizzy at home, and also check the ortho blood pressure.
Okay, tell me what orthostatic changes mean.
If there's a drop in blood pressure when they go from supine to standing.
Okay, perfect. Okay. And he was, okay. And then what about the advise him to drink more fluids when he goes home?
I don't think that's sufficient. He needs care right away.
You're absolutely right. Okay. So, but we're going to go on with him because he's a little interesting. Okay. So yes, this is false. Randy's blood pressure is below normal systolic parameters. Consider what? Dehydration, vasodilatation, and systemic infection. Those are the 3 things that come to my mind in terms of differential diagnosis right away. Okay, question 2, normal range. What's your next step? Yes, retake the blood pressure, ask if he is dizzy, and check to see if he has orthostatic changes. Excellent, very good. All right, so next, let's do the physical exam. I told you he really appears sick, and again, he's got that flat affect, but his level of consciousness was good, and he was participating in the exam. His lungs had bronchi in his lungs. He had a cough when he took deep breaths. So when I was auscultating his lungs, he was actually coughing because of the deep breaths, okay? And it was very rattly in there. So bronchi is kind of a rattle, okay? And he had decreased breath sounds in his left lower lobe. Okay, so I could hear well, I couldn't hear it. It was kind of fuzzy in that left lower lobe. So what do you think my differential diagnosis is?
Pneumonia?
Yep, one of them is pneumonia. Yeah, okay, now let's just look, hold on real quick. Let's go to the cardiovascular. He's S1, S2 is regular, but it's rapid. It's 96, but he didn't have any murmurs. And his skin is pale, and he has decreased skin turgor. Why would his skin turgor be decreased? That would be dehydration. Okay, you know when you pinch the skin, it should go right back down? His had a little tent to it. Okay, and I told you his affect was flat. Okay, so what are your 3 differential diagnoses for this patient? We already said pneumonia. What else?
Hypovolemia.
Hypovolemia, good. Anything else you want to think about? You can add the incarcerated hernia to that differential list, and you can add the depression to the differential list, because you have to address all of them that you're finding, okay, in your exam. And then the other thing I would put in there was, I would say a rule out sepsis, okay? But you could put in there hypotension, okay, and he's not really tachycardic because he's not over 100, okay?
Is he?
All right. Okay, how do you think I treated this guy? Huh.
Sent him to the hospital.
Oh, that's what I wanted to do. Absolutely. How would you treat him?
I'd send him to the hospital.
Okay, perfect. Okay, so, and then what's your follow-up with him?
Follow up on discharge from the hospital.
Correct. Okay. All right. So let's see what's going to happen. So my differential diagnoses were depression, hernia, upper respiratory tract infection, pneumonia, asthma. He has a history of asthma. That's why I put it in there, but I didn't tell you that. So shame on me. But I would also say sepsis. Okay. Now, Randy refused to go to the hospital. I said, Randy, how about if I call EMS? No, I don't want you to do that. How about if I take you to the hospital? He goes, no, I don't want you to do that. Randy, you have to go to the hospital today. He goes, I don't want to go to the hospital. And I said, well, what's it going to take to get you to the hospital? And then he started thinking about it, and he said, well, I can't go right now because I have to go take care of the dogs. Okay, so that was a good thing. He had to take care of the dogs. But so it gave me some optimism that he didn't want to just go home and die. Okay, which he talked about. And then so basically what I did was I gave him the talk about, Randy, I think you're septic and you have to go to the hospital today. If you don't go to the hospital today, then you've made a decision to go home and possibly die. And I want you to know that. Okay? I took him out. He got in his truck and he said, I'm not going to go to the hospital. So I did order a chest x-ray for him and I put him on an antibiotic. Okay, and I always call the antibiotic goes electronically into the drugstore for all my patients so that he could get the antibiotic, all right? But he did not want me to call 911.
At that point, could you involuntarily have him taken because he was a danger to himself?
No, because EMS, if I called EMS, they wouldn't take him because he would be refusing treatment, and they can't take him because I can't commit him. You know what I mean? He's an adult making a decision.
Well, I know this is not something we'll ever prescribe, but would the antibiotics be a good call with the sepsis, or would that potentially cause more of a problem if he runs out of them or completes the course, but the underlying infection is still there?
Yeah. So what I did was I gave him a 10-day course of amoxicillin. Okay, but remember, my bottom line is to get him to the emergency room, and remember, he trusts me. So I got him into his truck, got it, and I said, Randy,
time for motivational interviewing.
Yeah, you're not capable of driving. I'm really upset with you about that, and I don't want you to go home. But he left, and about 3 hours later, I got a message from in the message system of our clinic, and he had called into the clinic to tell me he went to the emergency room. Okay, so the next day I actually did a visit. I went to see him in the hospital. Okay, so he's kind of like one of my. I hover a little bit with him because I worry about him. Okay, and so anyway. He told me the only reason that he went to the hospital was because I told him that he was very sick and that he trusted me. And he was septic. So he did get diagnosed with pneumonia. And so I haven't seen him since he got out of the hospital. So I have to, wait until I go back into the clinic, and I'll probably see him like next week. All right. But the reason I'm presenting him is because I want to make sure that you you as psychologists know that patients trust you. They might come to you before they go to anyone else, the emergency room, their PCP, their cardiologist, and you have to be pretty strong with them in terms of what's the next step, okay? Because he would die. He was septic, and he did have a sepsis activation, okay? And the reason that is that he basically had a community-acquired pneumonia that got really bad. He vasodilated. He was dehydrated on top of that. Okay, is that an okay conversation to have with Randy? All right.
Yes, that was good.
Okay, so and you might see Randys in your practice who are sick, and you've got to get that thermometer, or and you got to get the blood pressure and the pulse ox. Okay. So we're going to work for this session is just going to be an hour, and I'm going to try to get through as much as I can. I want you to watch the videos. We can watch them in a little bit at lunchtime, okay, so we can at least talk about a head-to-toe assessment. So, okay, I want to talk about pain and pain characteristics. And I have lots of stories, and you're gonna get stories as well about pain. So there's characteristics. It's acute and chronic. And then there's actually an acute on chronic, if you want to put a third type together, okay? The origin of pain is neuropathic, okay? Neuropathic is nerve pain. And then there's nociceptive pain, which is either somatic or visceral. So visceral is organ pain. Somatic is usually kind of muscle pain. All right, so here's a nice little case for you. So I have a young, she's a middle-aged woman. She's probably in her late 50s. She has chronic migraines, and I inherited her from the previous provider. I've been seeing her for over 3 years, and she takes oxycodones, 10, 275s, 250s.
Are you allowed to prescribe narcotics in Hawaii, or
yes, I have free prescriptive authority for
Okay.
Schedules 2, including opioids.
Okay.
But I have very, very few patients that I prescribe opioids on a monthly basis. Okay.
In Massachusetts, it's not allowed anymore. It's only prescribable once per week. And I think we can only give 7 pills. It's very, very restrictive now.
Wow, that's
I was asking, and I think it's also restricted to sometimes to inpatient. That's why I was interested in how it is.
No. So nurse practitioners in the state of Hawaii are totally independent. So even though I work for a physician, the physician is not in the clinic when I'm in the clinic. So
Okay.
I am totally independent. I can prescribe anything. I can't prescribe methadone and like buprenorphine. And mostly that's because I'm not certified, and I don't really want that population of patients. So I don't do that.
Okay.
And that's a choice. So I can do opioids. This particular patient has been one of my patients for a long time, and she does take pretty much 3 oxycodones a day for her headaches or migraines. Do I need to work on that? Yes, but she's also got bipolar disease, and she takes all kinds of I should use her as a case study for you guys, but she's on sertraline and topiramate. She's on all kinds of mood modulators, as well as her oxycodones. Okay, so anyway, she's pretty stable, and she doesn't go off of her oxys. She doesn't ever come in early and say, oh, I need more. So she's a stable opioid taker. So I'm okay with her, and she's highly functional. She works full time.
You have extended release? Sorry, am I allowed to ask questions or not?
Yeah, sure.
So you have her on extended, you said 3 times a day. So do you have her on extended?
Yeah, no, she's just on 3 times. I give her 3. I give her 90 pills a month. And
Okay.
she basically takes them the way she wants based on her migraines. Okay. And she's an art teacher, and she works in an art classroom in high school with kids who have, you know, different colognes and perfumes, and then the art materials have, you know, smells, and that's what triggers her migraines, are these odors. Okay. So like I said, she's highly functional, and she takes her oxys when she needs them. But she's, like I said, she doesn't ever go over them, over the 3 of the 90 a month. So she rides horses. And a couple weeks ago, she was getting off of her horse, and she twisted her ankle. But when she twisted her ankle, she actually fractured her leg. Okay. So the reason I'm telling you this is because now she's acute on chronic pain. Do you see what I'm saying? She's highly tolerant of her oxys, and they work okay for her migraines, but now we put on severe leg pain from the fracture on top of that. Okay. Are you with me? So she's going to be hard to manage. And so she came in, I got her a referral to an orthopedic doctor so that she could get her leg fixed, you know, her fracture repaired, because she needed surgery because of the type of injury. And then that was Friday. And on Monday she came back and she looked horrible. And she had really increased a lot of pain, and she had using a lot more of her oxycodones than she usually does. And now she's short her oxys. Okay, so now I'm in trouble, because now I need to give her more oxycodones to help her manage her acute on chronic pain. And so I actually, and I want to talk to you, they see the neuropathic and the nociceptive pain. So basically she's having somatic pain. She's not having neuropathic pain because it's not nerve pain. It's not tingling, burning. Okay. And so anyway, what happened, I actually called one of my colleagues who does palliative care and pain management, because I didn't want to, I knew I had to give her something more, but because of her bipolar and her depression, I didn't want to change up her psychotic, you know, her bipolar medications. I didn't want to add more things. And actually the palliative care MD said, why don't you give her gabapentin? And then I said, no, because she's on blah, 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 blah. And she goes, oh yeah, you're right. Don't do anything. So anyway, the plan was then that what we would do is just increase her oxys and get her to her surgery date, which was in the later part of the week, like Thursday. Okay. But what the other thing that I did was I called the pharmacy, because I gave her a prescription to increase her oxycodones, but I called the pharmacy and I said, just FYI, I have increased the number of oxycodones I'm giving her, and this is the reason. Okay. So that protected her. Okay. And it also protected me, because now they're seeing that the opioids are being prescribed by the same provider that always provides her oxys. And I'm covering myself saying I know there's another problem. Okay. So now I haven't seen her post-operatively. That was early last week. So I'm going to see her again too. But I couldn't really give her anything besides the oxys for now. Here's the best part, was she had come from the orthopedic surgeon visit that Monday in extreme pain. And you know what he said? Go see her PCP so that she can manage your pain. So he just kind of said, I don't want to do anything with this. Go back to your PCP. So anyway, you're going to see patients like this because they have chronic pain. They're getting opioids for migraine headaches, but at the same time, you're treating them for their bipolar or whatever that you're treating them for, right? So anyway, we got her through that week. She did have her surgery because I got a note from the orthopedic surgeon, and the operative note from the orthopedic surgeon on Wednesday or Friday. So we know that she's now at least got her fracture fixed. Okay. So that's a good thing. Okay. So let's go over to the other side of the slide then and say, what's about assessing pain? What's the severity of the pain now? And usually I use an analog. I don't use pictures unless I have somebody who doesn't understand. Like, I don't do many children, but if I have somebody who is cognitively impaired, I have some Down syndrome patients, some other people that, you know, have some cognitive, maybe some dementia or something, and I'll use pictures with them. But mostly for adults, I use analog, you know, 0 to 10, give me the severity of your pain now. Where is it, the location, what's the quality of it? And when I say quality, I want to know, like, is it intensive, sharp, biting, electric, burning, throbbing? That's the quality part of it, because when I ask them those kinds of questions, then I can differentiate the origin of the pain, okay? Because I know that neuropathic pain is going to be burning, not knife-like, electric, tingling. Okay, so anything that goes with the nerves are going to be, you know, those kinds of characteristics. Whereas, you know, throbbing, diffuse, sharp is usually something like somatic or visceral, okay? How often is it happening and the severity of it, okay? Onset, when does it happen? You know, does it happen when you get up and get active? Does it wake you up in the middle of the night? Those kinds of questions. And how long does it last? And then remitting and exacerbating it. What helps it and what makes it worse? And then any associated symptoms. So usually I'll say, you know, do you get nausea and vomiting? Particularly if I'm thinking that it's some visceral thing, I want to know if they've got abdominal symptoms. So diarrhea, nausea, vomiting would help me think about something in their bowel or gut and of that nature, stomach. Okay, are we good? All right. So here's the analog, the visual analog scale is on the top, and then the Wong-Baker picture scale is down on the lower end of that, just so you can use those as guides. All right, so that's the pain part of it. And the good news is when I was talking with the woman who broke her leg, I said, you know, post-operatively, we're going to really have to work on your pain management, and we're going to have to do something different. And so, interestingly, I had my psychologist who's doing the clinic with me. I had him see her the week before because she had come in for her normal routine opioid prescription, and they had a long discussion, and at the end of that we all decided that we were just going to keep her the way she was. We weren't going to change a whole lot because of the bipolar, the depression, and those kinds of things. And ironically, she comes back the next week with the fracture of her leg. So we had a kind of frank conversation, the two of us, about not the psychologist, the patient and I, about really trying to get off the oxys. And I think she got it. So we'll see how that goes. All right, so let's do physical examination stuff for the next 20 minutes or so, half hour before lunch. So, you know, there's a lot of variation on how people are treated. So just know that as long as you have a good plan and you have rationale for your plan, and you've documented that plan, and you've talked to the patient about the plan, you're in good shape, okay? So that's you know, documenting everything is important. And keeping people apprised of what you're doing. So the pharmacist actually said, thank you very much for calling me, because I would have called you, and he would have when he got that prescription, okay? All right, so let's do HENT. It's head, ears, eyes, nose, and throat, okay? And so you want to make sure that if somebody comes in that, you know, you're looking at their, you're probably not going to do a lot of this. And I only do it if there's a focused exam that I have something that, you know, they have itchies, or, you know, I have a rash in my head. Then I put my gloves on. Make sure you're putting gloves on whenever you look at a scalp. And you're looking for bugs or nevi or hair loss patterns. And with the face, you always want to look at symmetry, expression. If they have any little ticks, you know, those are little spasms. In the skull, you want to look for bumps. You also want to look at any color, pigmentation, any lesions of the head. We have things here, they call them ukus, and that's basically lice, but they are prevalent here, particularly in elementary schools. So be careful with the bugs. Always put gloves on. Okay, ears, always think about hearing. And eardrums, look in the canal. There's two types of problems in the ear. One is the external otitis, which usually is related to a lot of people that swim here will get an external otitis. It's a very inflamed canal, but the tympanic membrane is not. If the tympanic membrane is inflamed, then it's called otitis media. Okay. Okay, and then you want to look at any of the, if you want, you can look at air and bone conduction, but that's the Rene and Weber, which I don't really do very often. Okay, eyes are conjunctiva and sclera, the visual acuity. I don't look at the optic disc. If they have a problem, I always send them to an ophthalmologist or an optometrist, because I can't do an ophthalmic exam nearly as well as they can, and they can document it. And then usually if I have a problem, if it's an emergency, I'll call one of them that I know well, and he will usually take them and see them on an urgent basis. Iris, cornea, and lens. You know, a lot of times if they are using contact lenses, they have corneal abrasions, and that's very painful. And then we're going to look at the cranial nerves, okay? And then nose and throat, basically, I just look to see if the turbinates are enlarged, if there's any erythema, you know, redness, and then if there's any drainage. And then throat, I always look for erythema. I look for the uvula moving. I look for the tonsils. I look for exudate in there. And I will do a lot of throat cultures, all right? Because strep is something that needs to be treated. Okay, so I kind of keep the HENT exam. Oh, let me go back to the throat and the neck for a minute, okay? I'm not going to go back to the slide, but the thyroid and your lymph nodes. So I want you to, when you're looking at the video, I want you to see how I'm doing thyroid, the thyroid. I do it from an anterior perspective, and I just put my hands on, my thumb on one side and my fingers on the other, and I isolate the thyroid, and then I have them swallow. And when they swallow, I can actually feel the thyroid slip through my fingers, and I know the size of it, I know the shape of it. The volume of it's about 30 cc's, if you can think about, you know, 30 cc's being a elongated soft volume. And I can tell if there's nodules on it because of the way it slips through my fingers. You can tell the nodules. You can tell if it's asymmetrical. One side's bigger than the other side. And the other thing is you can see on their neck if one side of their neck is more swollen, because that's a goiter. And why am I really kind of concentrating on that thyroid is because you need to really zone in on thyroid with depression. Okay, every person that is depressed, that comes in and has a history of depression or their mood is low, I do a thyroid stimulating hormone on them. Okay, because I want to make sure that they're not hypothyroid. Okay. And then you can, you know, just make sure that there's no lymph node enlargement, and that would be, you know, under the mandible, the anterior chain, which is bilateral in the front, and then the posterior chain in the back. That's what I usually do. Okay, mental emotional status. The neuro assessment has 5 categories: mental, emotional, cranial nerves, motor, sensory, and reflexes. You know the mental emotional status probably better than any clinician, okay? I'm going to just do a little bit of, just so you understand the division between the autonomic and the central and the peripheral nervous system. So there's the central nervous system. Make sure you understand that that's the brain and spinal cord only. So the little diagram, brain, spinal cord, that's it. The peripheral nervous system consists of the cranial nerves and all the spinal nerves, okay? And then the functional divisions are the autonomic, which means that it's regulating the heart, the breathing, and those kinds of things, and somatic, which is the movement of muscles. And then there's the sympathetic and parasympathetic, and sympathetic is fight or flight, and parasympathetic is rest and digest. Okay, so, and I know that you're going to get all of this in your drugs. So what's sympathomimetic, what's anticholinergic, what's cholinergic, and those kinds of things. And that's going to make a difference down here with your sympathetic and parasympathetic system symptoms, okay? All right. So basically, here's the brain and the spinal cord. So we know that's the central nervous system. And then what I want to do is I want to tell you a little bit about this motor strip, okay? The motor strip, or homunculus is what it's called, okay, sits on the postcentral gyrus, okay, of the frontal lobe. So basically, if you go down and you kind of take, this is pretty clear. So what you see here is the legs are at the top of the strip, and the face and tongue are at the bottom of the strip. The reason I'm showing you this is because you can have damage to the homunculus, which is the motor strip. That's where the motor neurons start in the brain, and then those are the ones that go through the precentral gyrus. They go through the medulla, and that's where they cross over. So that if you damage the right side of your brain, it's the left side of your body that has the problem with motor. Okay, are you good with that? So, but it's called the homunculus, and it's just a pattern. But I can tell on my patients what arteries were involved in a stroke based on their symptoms, because I know how the homunculus works. So it's just fascinating. Okay, so here's the homunculus. So here's your legs at the top, and then there's no trunk because there's very little motor and sensory activity in the trunk. Look how big the hands are, and look how big the face and lips are, okay? And so that is the orientation then, okay, of the motor strip. And if you have a middle cerebral artery aneurysm that ruptures, you're gonna wipe out this side, almost going right into the face and the lips. Okay, so they have problems with language, especially if it's on the left side, which is left motor dominant. Okay, all right, so that's just kind of fun. That's the somatosensory, but here's the motor, and they're the same pretty much. All right. Just so this is kind of a review. If you don't know this, it's really good to know it, the motor pathway. So I already said it starts at the top. It's going to go through that internal capsule. If you have a stroke and it affects that internal capsule, you're going to have a profound flaccid paralysis that comes down. Well, actually, it's going to be flaccid in the beginning, and then it's going to be hyperreflexive and spastic later. But you can see here's where it crosses over. You see? Right? So I want you to review this at your own leisure. Here's the peripheral nervous system. 12 cranial nerves, and 31 pairs of peripheral nerves. The PNS delivers messages from the CNS to the periphery and from the periphery to the CNS. So the peripheral nervous system is just like a freeway that delivers messages back and forth to the brain. All right. But when you injure one of those nerves, then you don't have the communication, and that's what you're going to see clinically. All right, just so you understand spinal segments. Okay, so this is the gray matter in the middle that looks like the butterfly. And then here is a sensory tract and a motor tract. So sensory comes in the back door. This is a peripheral nerve, and the sensory information is going to come in through the back of the spinal cord, and it's going to intersect with this central gray matter, and it's going to do two things. It's going to go up to the brain and tell the brain something, and it's also going to come out the front part of the spinal cord to make the muscles move, okay? So the sensory nerve goes in and the motor nerve goes out. So when you have compression on either the sensory side or the motor side, you're going to have sensory, you're going to have pain, tingling, numbness. Motor, you're going to have, you can't use it, okay? The question is it a peripheral problem, or does it come from the homunculus? So the homunculus is going to have profound sensory and motor loss too. But the question is, how do you know the difference? Okay, and that is because of reflexes, all right? And let me just go into reflexes real quick, okay? All right, so this little cartoon is basically the same as that other one. Here's our sensory neuron, and it's coming in the back of the spinal cord. Remember I said in here, you're going to either take the information up to the integration center in the brain, but you're also going to send it out to an effector organ. So we're going to call the effector organ a muscle. So you have an afferent loop coming in. You have to have some sensation to make a muscle work, okay, or some command. And the information coming from the periphery might be, oh, okay, a fly is on my nose. Okay, so the fly is on my nose. I get that information. And what's going to happen is I'm going to send that information up to the white matter, to the integration center, and also to the effector organ. So I might wrinkle my nose to try to get the fly off. That would be a motor response. Or the white matter might just say, hey, whack it with your hand. All right? So the reflex is receptor organ, sensory neuron, intersection here with an association neuron and an effector organ, and out. The reflex does not include the integration center. So the brain is not involved in a reflex. So you have an afferent pathway, the connection in the middle, and then you have an effector or efferent fiber to move out of the reflex. So this is the reflex arc right here, okay? The blue connecting with the red, but it's not going up to the brain and to make the reflex work. Eventually the brain gets notified, but then the brain is kind of slow in that respect. Okay, so this is just, again, the components of a reflex arc: sensory receptor, afferent neuron, interneuron, efferent neuron, muscle or effector organ, right? All right, let's talk about responding to pain. So now you look at this as I hit something hot, and what happens, I immediately withdraw. And you can see in the diagram, you have the sensation and the withdrawal. It's immediate. That's a reflex. When the brain responds to that situation of, oh, I hurt my finger, or it burns, what's the brain going to say later? After you've pulled your finger off the hot stove, the brain's going to say, wow, that was hot, or, you know, holy moly, or shit, right? But you're not going to keep your hand on that iron until the brain recognizes that it's hot. Your sensory arc, your reflex arc has already responded to it. Okay? So that's a reflex. And then we can check reflexes with a reflex hammer. All right? And I'm going to keep going here for a minute. So how you differentiate that motor response I was telling you about. So an upper motor neuron comes from the brain and the spinal cord. And when you have an upper motor neuron, that's something like a brain injury or a spinal cord injury, what happens to the motor neurons is they get spastic and you end up with hyperreflexia. If you injure a lower motor neuron, and a lower motor neuron is something that's coming from the peripheral nervous system, either a cranial nerve or a spinal nerve, when you injure that, you're going to see flaccidity and hyporeflexia. The reason you see hyporeflexia is because the reflex arc is no longer intact because you wiped out either the sensory afferent or the efferent motor neuron, okay? So if I'm curious or I'm worried that my patient with cervical neck pain, is it peripheral or is it central, then I'll do a reflex check. And if the reflex arc is intact, then I know that there's no peripheral nerve damage going from that pain. So I don't have radicular symptoms, okay? It's a little confusing, so I want you to look over it again, okay? But here's the, sorry, wait, what did I do? So upper motor neurons are basically from traumatic brain injury, stroke, multiple sclerosis, cerebral aneurysms, arteriovenous malformations, or injury to the spinal cord. Something that has to do with the central nervous system, brain or spine. The lower motor neurons, it's a loss of that reflex arc, and it's usually an injury either to this motor neuron right here, injury to the muscle maybe, or loss of a sensory receptor, so that this reflex arc is no longer intact. And then you know it's a lower motor neuron, okay? And a lower motor neuron diseases are amyotrophic lateral sclerosis, progressive bulbar palsy, primary lateral sclerosis, progressive muscular dystrophy, post-polio syndrome, and any other muscle atrophy syndromes, okay? All right. So I'm telling you that is because it differentiates your motor and sensory findings from whether it's a stroke or something from the central nervous system, or whether it's something from the peripheral nervous system. Okay, I'm not going to go through this because I think you know this pretty well. Orientation, mood, behavior, speech pattern, word fluency, coherence and relevance, short-term memory, long-term memory, judgment, and abstract thinking. Those are the kinds of things that that you need to check on in the mental emotional exam. And as psychologists, you're doing all that. I like the mini mental status exam. There are many other exams for dementia, but I know this one, I use it, and I know that, you know, what my results are. So 30 is normal. If I get a 24, 25, you know, I'm starting to think about mild dementia, and anything under that, then I'm starting to worry. Always remember that when you're doing attention and concentration, like serial 7s, well, that's really hard for some people, especially my population, because they're not necessarily educated and don't have those skills. So I'll have them spell world backwards, or do something else that means that they have to, you know, concentrate on something. The clock drawing tests, remember that's a check of visuals. Make sure you know that they can see, but you want to see where they draw the clock. And if the construction is bad, you think about mild cognitive impairment, parietal lobe damage, which is stroke, dementia, or even sometimes depression and hypothyroidism. Again, those are just kind of little tests to look at cognitive function. Mental status changes, areas of concern are always things like hypovolemia, electrolyte imbalance, acid-base imbalance, infection. We saw that with Randy, but he was awake, alert, and oriented. Medications, particularly anticholinergics. Cardiac arrhythmias can change mental status. Hypoxia, hypoglycemia, abnormal thyroid function, abnormal liver function, abnormal cortisol function, hypercalcemia, and inadequate folate or vitamin B12. And remember that folate, inadequate folate or vitamin B12, the trigger there is going to be looking at your CBC and looking at your mean corpuscular volume, your MCV. All right, cranial nerves. I have a picture of those cranial nerves, but and I think there's a reference in your there's a reading in your reference folder on cranial nerves and what they mean. Okay, I just want to see if I have to go way back. I want to just get out of here for a second. See if I can do that. Oh. Okay. Oh, geez, that's not what I wanted to do. Sorry. So if you can see, these are the cranial nerves, and I want to make sure that you see that they're on the underside of the brain. And so you can take a look at this picture. And olfactory, I don't worry about. That's cranial nerve 1, because people's olfactory is changed by allergies, by smoke, by a number of things. So I don't usually test that. Cranial nerve 2 is the optic nerve, and it's sensory to the eye. So you need to look at vision and visual fields. Number 3 is the ocular motor nerve, and it does several things. It moves the eye up and down, and it vasodilates the eye. And number 4 and number 6 actually support that. When you're looking for extraocular movements, you test the up and down of 3, and you test the 6 by having them bring their eyes toward their ears, and number 4 goes medially into the nose. So that's the basically conjugate gaze, and that should be kind of conjugate. It's, if the left eye is going to the nose, then the right eye should be going to the ear, kind of thing. Number 5 is the trigeminal nerve. Trigeminal nerve has 3 branches. You can see it's got sensory to the face, the sinuses, and the teeth, and the motor nerve is muscles of mastication. So it's the masseter and the mandibular muscles, or the temporal and the masseter muscles. And trigeminal neuralgia, which is a real serious pains phenomenon, is very real and very difficult for patients. That 7 is the facial nerve. Remember, 6 is part of the conjugate gaze. 7 is the facial nerve, and it's muscles of the face. Now, here's something that I want you to either take a little note on or remember. so there's a peripheral seventh and there's a central seventh. So the peripheral seventh would be a hemifacial weakness. The whole side of the face, on the side where the facial nerve is injured or inflamed, the whole side of the face is going to have a paralysis. That's like a Bell's palsy, okay? If your eyebrows go up on both sides, let's say they go up on both sides, but when you smile, only half of the face can smile. That's called a central seventh. And that central seventh means that there is injury up in that homunculus, in that motor strip down by the face. So I just had a patient come in. She had a stroke. And when I looked at her face, I did her cranial nerve testing, and she had a central seventh. So both of her eyebrows went up, but when she smiled, only the left side of her smile worked. The right side did not. So that indicated that she had damage to that area of her brain. If I have a Bell's palsy patient come in, it's usually from some viral infection like a herpes or something, and they have a total hemifacial weakness. That's a peripheral seventh. So I just want you to be able to distinguish the difference on that. 8 is vestibular cochlear, and that's an inner ear. So you want to look for nystagmus, and you want to make sure their hearing works. Okay, and the other thing you want to make sure is that they have good balance. 9 is glossopharyngeal, and it's the pharyngeal musculature. So I don't usually put anything in their mouth to test the sensory part, but I usually just make sure that they are able to move all the musculature in their pharynx. 10 is the vagus. Remember, the vagus has that heart, lung, bronchial, GI tract connection. So, you could have a vagal response and actually slow your heart rate down so you pass out. So that's the heart part of the vagus, but there's also sensory to the vagus, and that's heart, lungs, bronchus, trachea, larynx, pharynx. Okay? And then 9 is the sternocleidomastoid muscle and the trapezius muscle. So it's a muscle one. You want them to contract and make sure that those muscles are working. And finally, the hypoglossal, which is 12, is muscles of the tongue. Usually I just have them stick their tongue out, and they do pretty well. If it's straight out, you know that both sides of the cranial nerve, the hypoglossal, is working. If it turns to one side, you know that the side that it turns to is not working. Okay, it's kind of like a rowboat. Okay, if you want to turn right, you then don't use your right oar, you only use your left oar. Vice versa. Okay, so let's do some quick stuff here. I have, I guess it's break time. Is that correct for you guys? We can take a break and come back and finish up the exam.
You're the maestro.
Yeah, okay, so I think what we'll do is we'll come back and just do the exam part. What I'd like for you to do is, Aiden, can you show those videos for like the next 15 minutes or so? And then they can have 45 minutes for lunch?